My name is Jacqueline Orr, and I'm a program officer at the Robert Wood Johnson Foundation in the Research Evaluation and Learning team. And it's an honor and pleasure to see so many names that I am aware of and friends and colleagues on this chat in this webinar. And I want to really thank you all for joining us today. We've gathered today to have a talk about a book called Necessary Conversations, Understanding Racism as a Barrier to Advancing Health Equity. It's a newly published book, which was edited by Alonzo Clow, and features the thinking and work of over 50 contributors representing academia, journalism, community-based organizations, advocacy groups, and many other areas within various sectors. The book actually explores the roots of health inequities in our nation, as well as how we can help move forward towards lasting change. The first step is to have necessary, vital conversations about racism. That is a barrier to health. We know that that is the first step. So RWJF, we worked with the Oxford University Press, which is the publisher of this book, to make the ebook available free of copyright and free for everyone to download and share along with your networks. And you can get a free copy if you haven't already done so at rwjf.org/necessary conversations. Again, that's rwjf.org/necessary conversations. So we're really grateful for this opportunity, as well as the interest in this conversation and the community of people that is bringing together today. We wanted to make sure that you all were aware that in the coming months, we'll have much more evidence, practices, as well as messages and other tools to really help to share and for everyone to consider in your work tied to these types of conversations that we need to have. So a few housekeeping notes before we dive in. A recording of this talk will be available tomorrow, and we'll share links and citations that we mentioned during this program as well. Because we have such a big turnout today, many of you may have already seen that the chat is going to be disabled, but we will have the question and answer panel available, and that should be at the bottom of your screen. If you have any Q&As during the talk, we can try to address those questions. And we'll allocate about 20 minutes at the end also for any questions that may come about. So we also invite everybody to have a conversation about this on LinkedIn. Many of us have posted on LinkedIn about this, and we can continue the dialogue there as well. So for many, Alonzo doesn't need an introduction. For those who don't know him already, it's my pleasure to say a few words about my boss. This is my boss. So small plug that this is Alonzo is my boss. But I wanted to just introduce Alonzo to folks that may not be aware of his background. Dr. Clow has been RWJF's Chief Science Officer and Vice President for Research Evaluation and Learning since 2014. He's responsible for aligning all of the foundation's work with the best evidence from research and practice. Prior to RWJF, Alonzo was Vice President at the California Endowment. And outside of philanthropy, he has served as Emergency Preparedness and Response Director for the LA County Department of Public Health, and also a Director of Public Health for Seattle, King County, as well as Boston's Public Health Department. Alonzo earned his PhD and MA from Cornell University and his MPH, Masters of Public Health at Yale University. He's held a number of academic appointments at Harvard University School of Public Health, Tufts University Department of Community Medicine, Boston University School of Management, and the University of Washington School of Public Health. Alonzo has been the recipient of numerous awards for public service and leadership, and he's the author of an extensive body of scholarly articles and books, including this latest book just published called Necessary Conversations. So Alonzo, welcome to the webinar.
Thank you, Jackie. Thank you for that gracious introduction.
No problem. So I just gave a pretty abbreviated summary of your esteemed career within public health. And you've also worked in academia, philanthropy, and you've headed these major public health departments as well. So throughout your career in all of these arenas, you've had a really sharp and steady focus on achieving health equity. Can you tell us about kind of your origin story and when you came to understand that racism is a significant barrier to health and well-being?
Great, Jackie. And I'm going to turn the tables on you after I do that, so you can also share your story arc as well. Again, really glad to be with all of you today. So I'm going to start at the very beginning, at birth. But I'll move quickly so I get to other stages. But so I was born in Kansas City, Kansas, in Frederick Douglass Hospital, a hospital for Black physicians who were just not able to practice in any other places in Kansas City. And there were 2 university hospitals there who had to bring their equipment to Frederick Douglass Hospital. That's where I was born. And I think, that characterizes the long arc of marginalization that where racism has influenced health outcomes. And, though I was there at the birth, I don't remember it, but my parents, again, made sure that I knew that origin story. My parents, 2 HBCU graduates, teachers, civil rights activists, during the 50s and 60s, I lived through a period where I saw signs that said colored water fountains. I took part with my parents, made sure I was with them when there were lunch counter sit-ins. So you see, early in the origin story is a clear lived sense of injustice. And but keep coming back to my parents. My parents were very important in all of this, an imperative that we do something about confronting that injustice. And so that's been a part of all of the trajectory of my work. When I got to graduate school and did my dissertation, it was on racial differences in end-stage kidney failure, end-stage disease outcomes, some of the initial epidemiologic work, but also qualitative work on why that particular problem disproportionately affects Black and brown populations. Even today, you go to a neighborhood and you see a dialysis center, that's a Black or brown neighborhood. So that was kind of the academic part of it. Quickly became a little more action-oriented in my academic work, wanted to be part of solving the problem and not just writing about the problem. That got me into the first directing the public health department in Boston, later in Seattle, working on these issues in a number of different ways. We call it health equity now. We call it confronting structural racism right now. That the language changed, but the focus was always there. And I've just, again, had the privilege to carry on that work at this foundation as we are really dedicated to being a partner in root cause analysis of these problems, but more than that, action pathways to really address structural racism's impact as an impediment to health equity. So Jackie, that's my arc. I have about 35 or so years on you. Why don't you tell us a little bit more about where you would pick up the story in your experience?
Sure. So I think for me, I heard stories from my grandparents and great grandparents. I grew up in Detroit, Michigan. So there's a storied history of like 18 Black hospitals back in the day that provided care to a number of individuals, especially as the increase in individuals moving from the South, like that great migration up north to have the resources available for employees that were working in the auto industry. That was part of this demand, right? So hearing about that growing up, but it didn't necessarily click for me until I got to like more of the training related to public health. But I think I also, my father's parents grew up, they bought a home in what's considered to be Southwest Detroit. And this zip code 48217, many people may be familiar with it. It's very similar to Cancer Alley in Louisiana. Many of the neighborhoods within this zip code have had an increased rate of cancer and other issues as a whole that have been a direct impact of environmental injustice that has happened in that neighborhood. So there's a highway, 75, which is a freeway that runs basically from the top of Michigan down to Miami, is one of the issues. But then across the street from the highway is a petroleum plant. So many of the individuals, including my grandfather and father, they ended up having diagnoses of cancer as a result of living in those areas, but not being able to have the language to articulate some of those issues that I saw growing up. it was an ability, I guess, to go and kind of shift into more of the public health space, because as an undergrad, I was environmental chemistry and learned about environmental toxins and did a lot of research tied to like the polycyclic aromatic hydrocarbons. It's like very technical language, but we learned what happens in the soil and I went to undergrad in New Orleans. So understanding that there was an impact of emissions that happened, as well as all of the other things that were happening as far as chemical plants and the like in those types of cities, the type of impact that they would have. Having the language to be able to speak to that from a public health perspective probably happened once I moved and was in St. Louis. And so Homer G. Phillips is a hospital in St. Louis, the Black hospital that I learned a lot about there. So like understanding the policies as well as kind of the historical perspective has really helped me, one, in more of my administrative, when I was in the administrative space for hospitals, understanding how we can help these communities better understand the history to then be able to deliver the appropriate care to these individuals, knowing that some of them don't trust these systems, but then also being able to speak to it from a public health perspective and understanding that the influence that the policies have had on us from a public health perspective also can influence everything as a whole. So being able to sit at the table and have that language has been super helpful in my arc. And it continues, like even with the foundation, like having the ability within the foundation to be able to work on some of these from a much higher level of strategy and understanding how we can try to help to influence these discussions has really been a reward and a gift, I think, for me to be able to have a seat at that table.
And this history is so important in understanding the persistence of structural racism today. And Jackie, you raised the environmental issues. My Black neighborhood in Kansas City was like many neighborhoods where they decided to put the interstate highway system right through the middle. Atlanta, anywhere that, those sort of translocation decisions, those disruptive conditions that destroy community and disrupt well-being, much less the proximity to brownfields, toxic substances, sort of the center of the commercial center of the Black community in Kansas City when I was growing up was essentially next to a creek that was essentially an overflow sewage site. That has been a characteristic of the multiple structural determinants of ill health, inequitable health outcomes, just explicitly based on racism and marginality.
Absolutely. And having the voice, like there's something about the language that connects to be able to tell these stories. I think that is so important. And I think most of the time those communities have the stories, right? And that qualitative information is really important to connect dots, to be able to help one tell their story or have them tell the story in a way that can actually connect the dots for folks that may not have that historical perspective. But given that insight and lifting up that community voice, I think is really important in continuing to tell these stories.
Absolutely.
So let's talk about racism and how racism actually became a structural problem.
Well, big topic. And those of you, I hope you all get a chance to look at the book as we've been getting the book out there. The quip that I use is we have priced this book right. It is free and open access, and you just have to push a button and you get it. You download it. And I think that from many examples, life experience, academic policymakers in the book, you will see many examples about that from the book. And I'll just mention a couple of issues because they're persistent issues that speak to structural racism. And it's really important because all forms of racism are nefarious, right? So the in-your-face kind of racist interpersonal racism is bad. But structural racism is bad and sometimes even worse because it is embedded in principles and practices and policies, historical decisions that persist, where the person who is continuing it may not be even aware that they are continuing sort of the nefarious impact of those things. So we see that in redlining. Right, that created demarcations in neighborhoods, that created concentration of poverty and poor housing. We see it in the structure of inadequate community response, particularly to the ongoing health of Black women, so that we have maternal mortality problems, challenges, and disparities in this country, where we have Black maternal mortality rates much worse than many developing countries have, which is a structural issue. The historical issues that have marginalized and literally removed from history and experience are indigenous populations. A history of marginalization, discrimination, genocide. Again, reflected in policy structures and invisibility in data systems to this date. I would refer folks also to the recent National Commission to Transform Public Health Data that we did last year. You'll find it on our website. When people are invisible in data systems, when we lump Asian and Pacific Islander populations together in one group, and we don't recognize that those are dozens of distinct groups with histories and experience, those data do not allow us to understand with appropriate granularity and make visible the health equity challenges and possibilities. Jackie's already brought up the environmental justice issues. When too many communities, too many Black and brown communities are in these cancer alleys, in these brown fields, in these flood zone areas, those create and are correlated with greater poverty and a series of disease. And we could spend the entire session today on the incarceration system. I will not call it a criminal justice system because it doesn't deliver justice, but the carceral system is a systematic structural way to amplify inequity and poor health outcomes in particularly around Black and brown men. So it's just important. And I think from looking at all the you folks who are on this call, you have been working with and know this distinction between interpersonal racism, equally bad, but structural racism, which is really embedded in our history and our policies.
Yeah, I would say that I really could appreciate how the connectivity happened within the book, just from the perspective of, so everybody gets an understanding if you haven't had a chance to read the book yet. This is really part one of the book and how racism becomes a structural problem. So it really helps to offer like a framework to be able to address these things. And I think as a whole, like it was really insightful to see how like various historians and sociologists and journalists could come together to tell this, like to tell the story, but tell a more complete story, because we are providing like more of a historical perspective, which we can connect like I think it was the Mississippi Codes of like 1890, like there are clear policies that were put in place that show how that could have an impact on Black and brown communities within these states and within cities that happened over time that then have an impact on eventually have an impact on overall health. So I think I will plug that the fact that you can kind of connect the dots with a lot of the history is really important. And this is also including history that others may not necessarily use all the time. So I think it's a good resource for folks to have that you may actually be engaged with. And so go ahead.
Go ahead, Jackie.
No, I was just going to say, like, we know that there's evidence that racism is a barrier to good health. So can you give like one or two examples of what that structural racism could look like in everyday terms? Okay,
that's great. I was going to go back and just a little bit around the book. Nicole Hannah-Jones, who did the 1619 Project with the New York Times and has been unfairly attacked for raising these issues of the history that we just need to confront. She's the opening speaker, and we captured in the book, the urgency, and just the frank way she mentioned it. Our CEO, Rich Besser, sitting next to me, next to that presentation, I got this in the book. He turned to me right away and he said, "Well, we've lost the PG rating, and I guess that's it's necessary, because you have to talk about this frankly. You know, you got to engage people, but you cannot take the edge of urgency away from it, and the history that we need to confront. It's not just in the past." But Jackie, to the question about both the cumulative and persistent effects of discrimination based on race, we see it in just so many ways, and we talk about it in the work, and we work on it a lot within the foundations. Opportunity gaps. Even, oh gosh, how long ago was I in Boston? The 80s. I wrote a monograph called Diminished Life Chances, Race and Poverty in Boston, in New England. I mean, that is really what it's about. It's about diminished opportunity. It's about which goes beyond just access to healthcare or disease burden. It's about radical difference and impossibilities of getting generational wealth. Think about the interaction between redlining, right? Not being able to buy a house in where you want it, and the fact that most Americans' wealth is based in their housing. That's one of the major keys why marginalized Blacks and brown folks have not been able to build the kind of intergenerational wealth that other populations have had. So they're just these multiplier intersectional forces around racial injustice. And then again, as everybody on this call knows, it also expresses itself in population health and epidemiologic terms, huge life expectancy gaps. I hope everyone here has seen, and I'm sure you've been working with, the zip code maps that we've been funding for years. These major life expectancy differences in small geographies and cities just speaks to inequitable conditions in places that are based in racial injustice. When I show these maps, I often show one of the places that I try to live in, Los Angeles. If you land at Los Angeles International Airport and you start driving out to the city, about every, and this is non-rush hour, so you're actually moving, which is another LA problem. You're moving along, but about every 2 or 3 minutes, you're going to cross a neighborhood and you're going to be losing years of life expectancy. So by the time you've gotten from the relatively wealthy and usually primarily white west side of Los Angeles, as you move east, you're going to lose 10, 12, 15 years of life expectancy in those adjacent neighborhoods. And often when you present these data to folks, they find it shocking, but it's a fact. And Jackie, I think that speaks to the cumulative effect of racism, the persistence of the historical issues, and the influence of these structural factors.
Absolutely. Thank you for that, Alonzo. So we know racism can be both intentional and unintentional. And we sadly and repeatedly see news coverage of these overt hate crimes that continue to happen. I think the murders at the Tops Market in Buffalo is a recent example of a tragedy tied to overt hate crimes. And we know that these overt acts of racism persist because there's a structure that undergirds this to support racism. And so I really want to focus in more so on the structural barriers that are unintentional and maybe even well-intentioned. What do those look like, and how do they actually happen? How do those barriers actually happen?
This is a complicated question. I'm gonna get a little bit off script, and because I can't mention Buffalo, what happened in Buffalo, Jackie, without a little bit more on the persistence of history and how pernicious this is. Because the killer who drove, I went to Cornell. I know how far he had to drive in upstate New York to go and kill Black people. He was basing his hate and anger on a book written by a Belgian academic, now fortunately taken off his post, but it was a treatise and a set of work that could have been taken directly from 18th century racist literature. The book called A.O. Lovejoy, The Great Chain of Being, that puts white Anglo-Saxons at the top, and as your skin gets darker, Southern Europeans, black at the bottom. I mean, it was as if that book was written today. So I do want to emphasize how deeply ingrained that gets, which is, I think, underlies how some of the unintentional work, some of the unintentional aspects of this. I don't think it is intentional. I want to link it exactly to that history. I don't think it is intentional that that engineers working with physicians to do algorithms to drive artificial intelligence approaches to radiological procedures to look at dermatology are racist. But if they, and this is a fact, if they do what AI does, build the database on old records, machine learning, it will capture all the biases in the past. And therefore, these algorithms create dermatological screening tools that don't work for darker skinned people, misdiagnose. So that is not intentional. I talked to some engineers at Google. No engineer sits down and decides to develop a racist algorithm, but its impact is huge, particularly the way that tech drives healthcare. I don't think in recent U.S. medicine there's an intentionality to have clinical indicators and use race as a proxy as an inappropriate proxy for trying to understand the biology of disease, but that still happens, right? So it has to be interrogated. Why, if I have a kidney problem, there's going to be a different index of glomerular filtration rate for me, which is not true, and it I'm sure unintentionally by most nephrologists using that indicator, it really disadvantages my own health outcomes. So I think I mean, that's two examples of what it looks like around unintentional carrying of historically racist incorporations in data, in methodologies, in science, and in practice.
Thanks for those, Alonzo. And another one that came to mind is Dr. Julia Raifman did some work tied to understanding like a harmful policy in real time. And this was connected more so to COVID. So when the vaccines first became available, I think people that were 65 and over were given a priority. And those were individuals that probably had more of a likelihood to be able to isolate and stay at home. However, the frontline workers and essential workers were shut out of that opportunity and they were at greater risk, right? So we knew that demographically, there were probably more people of color and those individuals that were living below the poverty line that were impacted by that policy. And that was kind of a real-time opportunity. And Dr. Raifman has some amazing work. If you guys want to see that, we can drop that information in the link as well, in the chat as well, because I think that really shows, that's another example, like the two that Alonzo already shared, of how these health inequities can actually happen. And we have like examples from like very, very back in the day up until I guess a few months ago or a few years ago as well. I think every day we can understand how some of these policies will impact individuals on a much larger scale than we anticipate. So Alonzo, the book is actually bringing kind of the humanities and sciences together. And so it's I guess, of course, the nerdy girl in me loves the fact that like the scientific research is there, but then we also have like the storytelling, right? So it can really help to drive that narrative change. So let's talk about how as a society, we really need to shift these narratives and how we should go about trying to do that.
Yeah, we have to confront the narrative and change the narrative to embrace and confront all the things we've talked about before. And storytelling, social science historians, we really need to change the narrative about race. We have data systems that only measure disparities and disease prevalence outcomes and don't try to look at asset building. We have things like the CDC Social Vulnerability Index that should actually more tell us how communities should thrive. So we have a lot of ways that we have a narrative that reinforces marginality in data systems and the way we characterize populations. So it's really important to lift up experience of people, and particularly those folks who are on here that are researchers, bring narrative storytelling and the voices of experience into our analysis, into our mixed measures analysis. And that involves, and we're working on supporting this within the foundation, a whole new evolution of deeply community engaged and even community driven research on what it means to address these, because the manifestation of structural racism is very place specific, right? We're doing a project with a consortium of HBCUs in the South, in the Gulf South, that is the manifestations are many, all the things we've talked about at the same time. Cancer Alley in Texas, disproportionate impact of the extreme weather events there. I mean, it's all, as well as the legacy, historical legacy of structural policies and procedures in that part of the country. And it's really important to develop a different way of looking at data and engaging communities around what it means to have actionable and engaged public health data in that part of the South. And I encourage you to look at the development of this program in collaboration with the Gulf Research Program at the academies. I also should put in a plug. You will see an RFP for that program. And Jackie, you may want to put in a plug for what you're doing with the Beaumont, as we are trying to figure out how we can be a catalyst for disrupting, particularly data systems and public health practices that kind of replicate some of the problems and make them more robust to kind of address them. So it's really important to even go beyond what we call community-based participatory research to community-driven research, a whole new generation of what it means to do equitable, non-extractive research and non-extractive evaluation. We need to diversify who are researchers, and the foundation is working a lot on changing that pipeline. We need to interrogate and keep removing old algorithms and different clinical indicators that just really are based on erroneous concepts of the role of race in the biology of disease. And again, please look at our report on transforming public health data. Much more nuanced, disaggregated, meaningful, and hyper-local information to drive collaboration to address these issues.
Thanks for that, Alonzo. So I think what we want the audience to understand is that many of our grantees now, like, I think health equity is really central to the foundation's work. And so most, if not all, of our funding opportunities that have come out in the past couple months and probably the past couple years have really been designed to address health and well-being in equitable ways. And so one of those is what Alonzo mentioned. I'll put in a slight plug for some work that I'm doing with the De Beaumont Foundation. So we have an opportunity that will be coming about that really focuses on community-driven change, and it's tied to data systems and understanding what the community will need within utilizing those data systems, but also through a lens that actually brings racial equity into this work. So there'll be an opportunity for 5 communities to work with technical assistance and also helping us to understand what's necessary within these communities. That will be released next week. I believe it's June 22nd. So we will post additional information about that on LinkedIn and Twitter, but there is an opportunity, especially to incorporate some of these data-driven practices that work with communities at the table and having them actually influence what is necessary for them to become a much more, I guess, improved health within their community as a whole, but they will have an opportunity to utilize various data sources to do that. So I put in that plug. Thank you, Alonzo. I think just because we're in the research, evaluation, and learning space, it's probably important to talk about how we feel like research and evaluation has to evolve in as a part of these conversations. Like from a historical perspective, we're aware of some of like the evaluation practices and methodological approaches that may have had an impact on what we actually evaluated, who was able to evaluate. But I really want you to say more about like where you think we need to shift within that space in order to help with these conversations as well.
Yeah, Jackie, I think we really, and we're talking about it at the foundation, across the foundation, we have to really interrogate some of the basic assumptions of what I would call population health and health research, right? And we have to work at this in a number of different ways. I mean, we've already mentioned that we don't have the right we don't have the right concentration of underrepresented folks as researchers. So there's that piece as well. But it's more than that, because if we just kind of replicate methodologies that are really not going to help us get to health equity, we, in spite of ourselves, become part of the problem. You know, I spent some of my career doing that when I was doing mathematical models of disease. So I think that we have to interrogate the methodologies. Why do we have such a hard time in research doing mixed method qualitative quantitative work? Why can't young faculty, particularly young faculty of color, get appropriate counting for tenure and promotion for collaborative work done with communities? Why do some of the high impact research journals not even want to take papers where racism is a part of the problematic? Why do Black and brown researchers have trouble getting research grants from NIH institutes because they have that construct in their research proposals? So it really, we are talking a lot about how do we transform health sciences knowledge building so that it builds the kind of knowledge and it builds it collaboratively with community voice and a diverse perspective so that it can help us solve these equity problems. That's not saying that we are tossing out all Western science. I've been in conversations with folks. I said, no, yes, its foundations might have been cruelly defined as generated 200 years ago by old white men. That's true, but that doesn't mean that we toss out that entire canon. We are selective in how we use it. We interrogate it, we revise it, and we bring in a whole lot of other methods and approaches that we need to kind of create the kind of research that leads to equity. So it is. I'm enough of and Jackie and I are kind of like the same of this. We're enough of a research nerds. We know that some of these methodologies and some of these tools are absolutely essential. We want research to make a difference. We want it to be roughly replicable. We want it to be compelling so that it can influence policy. But we really need to have broader sense of evidence, community voice, and a good mixture now of nuanced, particularly ethically and racially disaggregated data. And we're all in as a foundation on that.
Absolutely. And I'll definitely say, I think I've been with the foundation almost 3 years. And so one of the initiatives that the foundation has brought about is the Equitable Evaluation Initiative, which has helped us internally even shift our thinking in regards to evaluation and how we approach those evaluations. So Jared, shout out to you and your team for an amazing job with coaching us through the Equitable Evaluation Initiative and being able to utilize those principles in a very different way, which I think can also help to shift some of this narrative. So Alonzo, there are 3 parts. Like if people have not had a chance to take a look at the book, there are 3 parts really to the book, where the first part is pretty much a framework that shows you how frameworks have helped to support institutional racism. And then there are examples that in part 2 that show specific impacts on specific populations. And it specifically speaks to Black women, individuals that are incarcerated, and individuals that have migrated from other locations. So I think it gives some context and some pretty good examples. And then the final part is to how to move towards racial equity. So it's 3 parts, and I think you get pretty substantial examples of how you can move this work forward and how other organizations have done that within the within the actual book. So Alonzo, what's the main takeaway? Like, what do you want the audience to take away from the actual book?
Um, um, well, I'll go with the title. When we have to talk about racism, we have to bring life experience into it, all of our life experiences, and we have to have this dialogue. I was at one of the many meetings I'm at the National Academy of Medicine just yesterday, where um, and I was very pleased to see that some of the one of the leaders of the academy brought a strong equity and structural racist framing to the work that we're actually doing on trying to get at the root cause of the substance use disorder problem, right? Which is deeper than prescription opioids. It's fentanyl. It's the history I dealt with when the problem was mostly Black and brown folks in the 90s. And, but that there was a lot of blowback because it makes people uncomfortable. Well, we have to have these uncomfortable conversations, particularly on the side of the formal health science side. So it was good to, I was happy to be part of a uncomfortable conversation at the National Academy yesterday, because out of that discomfort, and I can see it happening in the meeting, are people understanding that you've got to deal with it. It's vital that we understand it. I think if we really understand structural racism, it helps people to understand the unintended consequences often of it, and not move initially from a dialogue that makes it necessarily divisive. It's a collective thing that we have to do to deal with these structural elements of this. So I think we just have to. I think it's very important that we talk to action. We confront it in its many manifestations, and then we use I'm speaking as a researcher activist. We continue to build the evidence and data that just push the right kind of policies, and we do it aggressively, and wherever those issues are still manifest. I think we've moved a long way. People were not even talking about social determinants in that early part of my career trajectory I talked about. We have moved along. We're talking about it more explicitly in the foundation than when I came 8 years ago. I'm making up this number. There are hundreds of new centers on health equity research around the country, and many, many community groups that have been the driver of this. So we need to do this all together. And the last thing I'll take away from the book is the knowledge and the actions to do this are going to come from all the things I mentioned. If you don't leave it to the academicians, the policymakers, and philanthropy, this is going to come from the deep community engagement and community leadership. And we're really trying to align a lot of our foundation priorities to build those capabilities, that power in the communities, to be an effective driver for this kind of change.
Thanks for that. So that is the end of our chat, but we wanted to give an opportunity for folks to ask questions. So feel free to submit questions on the Q&A panel. We do have a few questions, Alonzo. We can start with those. This was from Ariel Juberg, who said that many people think of health issues in terms of personal choice. How can we best introduce these structural issues when folks are used to different framing?
Very important consideration. We have said from the earliest we've been working on the foundation about this. We worked on this in California Endowment too. You can't make choices you don't have, right? So you cannot make choices to buy healthy fruits and vegetables if you have to take 2 buses from your neighborhood to get them. And you live in a neighborhood where what is available is preponderantly fast foods or the analogous kind of quick stop grocery store. You cannot make choices to do a lot of running and outside physical activity if you do not have safe streets or access to parks. right? You can't have better work-life balance if you have to hold two jobs and take buses to them every day in order to meet your at least a minimal standard of living. So choices are in a context of what is available. And if there are structural inequalities that limit those choices, it's not all about personal choice. I don't want to discount at some level there personal choices one makes, but we cannot discount the limitations that these structural conditions place on the ability to make those choices.
And another question came in that stated many current sociologists are searching for and refining different frameworks for understanding structural racism. What makes yours different, and which other historian or sociologist theories do you incorporate?
We are incorporating everything that we can find.
Yeah.
And things that we fund and things that we don't fund. I can just speak right now to the research we've been funding and will continue to fund. We are trying to find and provide funding to a wide range of researchers and theoretical approaches to this. We will be able to get out pretty soon, and I think we'll do it also in an open access Oxford Press series, a compilation of 10 or 11 papers on structural racism written by many different authors and perspectives across the country, some sociologists, some historians, many names that you will recognize if you've been following it. I want to be really clear. We're not coming up with the Robert Wood Johnson Foundation omnibus theory of how to address structural racism. I mean, philanthropy is often full of hubris, but we don't have that much. We are synthesizing, we are drawing, we are learning with everybody, and we are incorporating in our work all of what goes on. And we have funders. I don't want to start mentioning anybody because many of the people we funded are doing great work. I would just say, go on our website, look at the range of folks that we have been funding to do this work across the foundation, and you'll see that we are drawing on and synthesizing all of those sociological, political, historical contexts for looking at this problem.
I agree. I think I was just going to say that RWJF is more of a platform to be able to lift up a number of different theories as opposed to one, like Alonzo said, we are not trying to push an RWJF theory tied to this. It's having the ability to incorporate many different theories and many different thought processes, some that may not necessarily be in line with each other, but providing that type of diversity is very important. Diversity of thought is really important. This next question, I'm not sure, Vanessa, the question is, how do you get around funders of minority research that often steer the outcomes and are often used? I'm not sure if, Vanessa, if you can provide additional insight, we can come back to that question because I'm not sure we can fully answer that at this point. Tassie Warren had a question about, could you speak more specifically to the kinds of research that we'd like to see happen? What kind of questions would we like to see investigated?
Big question. We would like to see more research so that we can remove any of the existing inappropriate clinical indicators that are based upon an erroneous assumption about race and the biology of disease. So that's really important. We need research that supports how you build and use and create interoperability, so we have more disaggregated ways of understanding race than the current classifications. We need research that helps us both understand and address amplifiers of structural racism, like climate change, a huge amplifier of structural racism in its implication, extreme weather events, really connecting the dots to show that climate change is a major amplifier and needs to be addressed through particularly adaptation and eventually mitigation strategies. We need research that moves from measuring disparities that shows us pathways to action and change, and embraces metrics and measures that show that we can improve health equity in many different ways. And we have some grantees that are already working on what should be these health equity indicators. What are indicators and measures you look at that show that are moving in an anti-racist direction, and much more interdisciplinary, transdisciplinary research that brings all of the different research traditions we've talked about, humanities, science, epi, together to look at this problem in a transdisciplinary way. And we are trying to do that already in our we call them pillar research programs. So look on the Foundation's website: policies for action, evidence for action, systems for action, data for action. They're redundantly named because they are all trying to be integrative, collaborative, interdisciplinary research addressing now primarily health equity and structural racism.
Thanks for that. And so Mimi Kaiser mentioned that hard conversations about racism are important, and the conversations are self-examine oriented related to white privilege are important as well, so that people are more open to seeing structural racism. And they're wondering, do we have any recommendation for tools, processes, or the like to guide that kind of engagement and storytelling within this space of racism, of talking about racism?
We're working on that. Jackie and I have great colleagues in communication, and my colleague, who's the VP of communication, recently brought on, is working with us around these tools for narrative change. How do we understand what parts of the current narrative on race need to be changed, and how can we create more robust, more equity affirming narratives? And we are trying to compile the approaches, which come from lots of different disciplines, to see how we can understand how to do this narrative change work. I would say we're in the early stages of doing that, but I think you will find some of that narrative change work already in some of the projects that we have on our website, but you're going to find a lot more opportunities for funding and more discussion of what we've been doing around these tools around what it means to do narrative change. And we aren't alone in this. California Endowment, I think, really was a leader in philanthropy around trying to change the narrative on race. So I think a number of funders are working in this area and trying to develop really practical community-based case study toolkits on how you do this. I think a lot of it is also we've got to move from just negative indicators to positive well-being asset indicators, so we're not always characterizing our communities by deficiencies.
Absolutely. There was one question from an anonymous attendee that asked about having these discussions with patients. And I think I just want to reference that there are a number of best practices, probably within more of the healthcare delivery sphere, that could speak to that. And I think I saw one of my colleagues, Dr. Craig Lowndes from Penn Medicine here, who could speak to more of like the patient experience and how they utilize Press Ganey data to actually advocate for patients and to develop a patient experience within a healthcare system. There are probably best practices that just given the time, we only have about 4 minutes left, that folks could probably speak to in having those types of conversations within more of the patient care setting. So I did want to acknowledge that question. I think Vanessa's question was edited. Thank you for that. I think her question is, how do we navigate the outcomes of research that are often paid by giant corporations, and the outcomes and data are often used and skewed towards the funders' needs as opposed to that of the public? So I guess she is probably speaking from her perspective about how to utilize those research outcomes for her own personal research, I'm assuming.
Yeah, you've raised an important question. And we're trying to work. We have a project. I would encourage you to go to the Tulane School of Public Health website on this National Learning Consortium on Health Equity Research, where we're bringing together funders, public and private, as well as researchers and community knowledge builders around what does it mean to do health equity work. The problem of corporate funding is complicated, as you raised, Vanessa, because the research is often tied to product development, right? It really needs to be looked at closely on case by case basis, whether this is part of the solution or part of the problem. I'm personally kind of inviting to see how all of that can be aligned, but I think and we're working with folks who do primarily a lot of funding, both governmental and corporate, on essentially what are clinical trials. So at least those are equitable in their composition and the target group. But that is a worthy issue that I think we're kind of scratching the surface on. I'm always an optimist. We need to bring in the corporate funders so they are part of the solution of this equitably oriented research, or at least can bifurcate and be very transparent and clear when the research is supporting essentially product development versus population health improvement.
Thanks for that, Alonzo. So we're running out of time. I think we're almost at the top of the hour. So again, I think the links for the book are provided to you in the chat. There are e-copies available for everyone. So folks that are preparing their syllabi for the fall, feel free to utilize this as a resource as you prepare those syllabus for folks. And I really appreciate all of you taking this time to spend this hour with us today. And I want to thank Alonzo for joining me and also for editing the book and sharing your deep insights with us today. I'll also like to thank Margarita, Grace Norman, and Kristen Silvani. All of your work has been absolutely amazing, and we appreciate you a great deal. So thank you all again. And again, the recording will be available tomorrow, and additional resources will be sent along with that. So again, thank you, Alonzo. Thanks everyone for joining us. Have a great day and be well.
Thank you. Thanks, everybody. Good talking with you.